Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemareg.
And let's get started on today's topic.
From basics
to brilliance. Hello everybody. I just wanted to say a few words before we start the podcast today. We're very lucky, as part of our Red Cell series, to have lots of guest speakers lined up to help supplement our knowledge. As you may know that in the Southwest, there's not as many patients with red cell disorders, and so our exposure as a team is more limited than potentially other areas of the country. And today we're very lucky to have Noémi Roy as a guest speaker and teacher. Noemi is a consultant haematologist and associate professor in Oxford, for which I did my red cell placement with, and she has a special interest in red cell haematology, in particular haemoglobinopathies and rare inherited anemias and iron optimization. So we'll be sure to pick her brains about all of these things during our red cell series. She's an honorary senior lecturer at the University of Oxford, and she's a really passionate teacher. She's a member of both UK and European guideline committees, and she's an author on the most recent BSH guideline on haemoglobinopathy diagnosis and screening. So without further ado, let's get on with the episode. Hello, so welcome. Today we have the eminent Dr. Roy from Oxford, who is a big dog in all things red cell. Is that fair to say?
Well, I don't like dogs. I'd rather be a big cat, but yes.
Okay, the big cat. Yes, of course. So we're very lucky and very grateful to have you here today, Noemi. So thank you so much.
Pleasure, thank you.
And we thought we'd talk about just the basics of lab techniques on how to diagnose different red cell disorders as a general overview today. And hopefully you can make sure that we discuss the things that you think are important that we know.
Yeah, I think when you say red cell disorders, I think we'll focus really on haemoglobinopathies because
good point.
A whole host of other red cell disorders we can do another time, like all the hemolytic anemias.
Brilliant. Okay, and last week David and I just discussed the real basics of the difference between a thalassemia and a haemoglobinopathy from a variant. Yeah. So just to recap that, a thalassemia is where the structure is normal but the rate of production of one of the chains, the globin chains, is slow. And a variant hemoglobin is where the structure is altered. So it's not about the rate of chain production, it's about the actual structure of the chain, like hemoglobin S or hemoglobin D. Okay, cool. So
sorry to interrupt.
Yeah, please.
Hemoglobin E, which is the one that's kind of a bit of both.
Yes, the thalassemic variant. We did talk about that as well. Yeah. Great. Okay. So I think maybe the first test to talk about is the full blood count. As a place that we would probably all start in terms of looking for a possible haemoglobinopathy or thalassemia. Noemi, what do you think are the most important kind of things in a full blood count that you look for that would make you suspicious for a haemoglobinopathy or a thalassemia?
So obviously, when we're looking at the full blood count, we're used to looking at the hemoglobin and the MCV. That's what most of us have been taught in terms of looking for cause of the anemia.
Yeah.
But in hemoglobinopathies, we do this slightly differently. So we also look at the red cell count. So this is important because we know that with hemoglobinopathies, we expect the MCV and the MCH to be low. So the mean cell volume and the mean cell hemoglobin to be low. But that happens in iron deficiency as well. Right. However, if you think about iron deficiency versus a thalassemia, what's going to be the main difference is going to be the red cell count. So the red cell count will be raised in the thalassemias, but it will be reduced in iron deficiency. Yeah. Having said that, we would always want to see a ferritin when we're interpreting a hemoglobinopathy kind of result. So we want to be sure that the patient is iron replete.
Yeah, yeah. Okay, brilliant.
So that would be the minimum you would expect before. If I sent you a referral, you wouldn't snarl at me.
Well, the thing is, most of our referrals that come through, especially for screening, so for like the antenatal screening, we often don't even have the ferritin. So sometimes we have to report it and say, this must be interpreted in the context of a normal ferritin. So it's not like we would say you can't, we won't interpret the test unless you send this ferritin as well. But it's nice to have the ferritin. There is one thing that we would absolutely require before we run the test, actually, and that would be consent. So quite often when you're requesting this, whether it's paper requests or on a sort of electronic patient record, there will be a tick box to say you've discussed with the patient that they've consented for this,
Yeah.
even though it's not a genetic test. And the reason for that is when you're doing your investigations, let's say, you've got somebody who's S, somebody who's C, whatever, even though this is not a genetic test, you could easily pick up non-paternity from this test, and therefore
Okay.
that's why we require consent.
Okay, that's a really good point. I remember you saying that to me actually when I was with you in Oxford.
Mhm.
Okay, cool. So basically, thalassemic indices are, when someone says that, are looking for a low MCV but with a raised red blood cell count, and that could
Correct.
indicate either a trait or a thalassemic disease.
Correct.
Okay, great. That's really helpful. So then I guess the next question is when would we move on to doing HPLC? So you've said we'll do hematinics and we do a blood film as well, I guess,
Yeah,
which
it
will
would.
be
I always like to see a retic count.
okay.
So any investigation for anemia, I would always want to see a retic count to see if it is normal, high, or low. If a retic count is high, then the person is responding to the anemia. That means that they're maybe they've got bleeding or hemolysis. If
Hmm.
the retic count is inappropriately low,
Hmm.
then that means something is blocking the production of red cells or their maturation and coming out into the bloodstream. So I would like to see a retic count. But yes, if you've basically got thalassemic indices and you think this could be thalassemia, you've excluded iron deficiency, then you would move on to your next test, which is in many cases an HPLC,
Hmm.
which is high performance liquid chromatography, but not necessarily for every hospital
Yeah,
doing it the
yeah.
same way.
Okay, fine. So basically, in a situation of an unexplained anemia, where it could be like a variant hemoglobinopathy or thalassemic indices on a full blood count, or I guess antenatal screening and neonatal screening, but we're not going to talk about that today
Yeah,
because that's a
yeah,
whole separate topic. Then those are the situations which you would then go on to do your next screening,
yeah,
which you said is usually HPLC. Why do I guess we should probably talk about what is the best test
yeah, yeah.
for looking for a hemoglobinopathy?
Yeah. The answer is there isn't a best test.
Hmm.
If I had to pick one test that was kind of high throughput enough and will give you as close a correct answer as possible, it would probably be mass spectrometry,
Okay.
which I don't know many labs that use it. It's
Mm.
part of the guidelines. You can use mass spec. It's so precise that you can mostly do it on its own. You don't need a second
Oh,
confirmatory
wow.
test.
Okay.
But not a lot of places do it. I think it's quite expensive.
Hmm.
So, yeah, a lot of places don't do it.
Does
So,
does it quantify as well with mass spec?
it must do, yeah, because it can
Okay.
be used. Yeah, so it can be used to replace basically the
Your
other
other
test.
two tests.
Yeah.
But that wasn't even on my radar.
Right, right.
So,
So I don't know many. I know of one lab that does it, but I don't know many labs that do it. And in a
mm,
way, it's kind of unhelpful to focus on that because A, it's not commonly used,
yeah.
and B, it's the one that's different.
Hmm.
So if we're thinking about let's learn about hemoglobinopathy testing, there's some key concepts, one of which is you must do two tests,
Okay.
okay? And
Yeah.
that's because at the end of the day, we're trying to determine one hemoglobin for another, and hemoglobins are very, very similar. So you'll have
Mhm.
like a point mutation and one amino acid difference, or you're trying to find different levels. We'll get on to talking about hemoglobin A2, but we're trying to find small differences in levels of a hemoglobin, which means that we'll need a second method to
Yeah.
confirm.
Yeah.
There is one sort of category when we don't need to confirm, and that is part of screening. So if we're going to do screening another day, but basically if you're screening and you think someone's got beta thalassemia trait and then their partner doesn't look like they've got anything, then that's it. We don't need to do any further tests.
Yeah. Okay. Yeah, that makes sense. Okay, so in general, if you're trying to diagnose somebody with a certain hemoglobinopathy, like variant, or a thalassemia, you do need to do 2 tests, because not one single test is good, except for mass spectrometry, which we'll ignore for now, unless you're in Oxford.
If you come down the M5, we don't have that.
No.
No, well, we don't do it in Oxford either. So I think some of the London hospitals do it. Yeah.
Okay, fine. Okay, and you said, I guess we should start with HPLC, because as you said, that's one of the most commonly used first tests. And I guess the general concept is that we are separating out various hemoglobins based on charge most of the time, with both HPLC and its kind of equivalent, the capillary electrophoresis.
So the difference between HPLC and capillary electrophoresis is that capillary electrophoresis separates on charge and mass.
Okay.
But HPLC, it's actually like an ionic reaction, if I can call it that. It's basically the ionic bond between your hemoglobins and the column. So shall I explain the test? Maybe
that would be brilliant. Yeah.
Okay. So first of all, the first thing to know is that we're not putting red cells through this. We're putting proteins through this. So we're going to burst lyse all the red cells so that we've got this kind of soup of all the different hemoglobins.
Okay.
And then that is applied to a column, and hemoglobins are basically negatively charged. The column is positively charged. So the hemoglobins stick to the column.
Okay.
Anything that's really unstable comes off straight away. And then you pass different salt buffers through the column.
Okay.
And the next less stable hemoglobin comes off, and then the next less stable hemoglobin comes off, etc., until you finally get off the most stable hemoglobin, like the one that's most strongly bound to the column.
Yeah.
And what you're measuring, and that's the other important concept when you're interpreting HPLC, is you're not measuring, oh, this is how much hemoglobin S there is, or oh, this is how much hemoglobin A there is. You're only measuring how much stuff came through at a specific period of time, which is a window.
The retention time.
Yeah. So we'll say it came off and it appears in the S window or the A2 window.
Yeah.
And because it's what we're saying is we expect this type of hemoglobin to come off the column at this time.
Yeah.
But you can't prove just by HPLC that that's what's in there.
Yeah. Okay. And that's, for example, you can get a hemoglobin E and hemoglobin Lepore can come off in the same window as what you would expect HbA2 to elute on. Yeah, exactly. So you have to just say that they run in the A2 window.
Yeah. And I think that's helpful to think of it like that, because otherwise, if you're looking at the HPLC, you're trying to interpret it and you go, oh, the A2 is such and such, what could give you such a percentage? But if you're thinking of it, if something came off in that window, oh, hang on, it might not be A2.
Yeah, exactly. Yes. Okay, that does make sense. Does that make sense to you as well, David?
Yeah. Do you know what it sounds like? Fractional distillation. I don't know if you did this at like geography in year 7 at school, where they put oil through these things, and as they sort of came out, depending on their weight.
Exactly. Yes. So, but like crude oil, we're starting with crude oil, and then we end up with the pure stuff. Yeah, that's it.
And for our exam purposes, we just have to learn the graph of what we expect things to come out at various retention windows. So I think bilirubin is like the thing that comes off first after the injection spike. And then it's FASC roughly as the windows.
Yeah. I mean, you will never be asked to interpret an HPLC trace without somebody telling you what the window is.
Okay, that's good to know. Yeah. Okay.
So a couple of things to say. One is, so the amount, so we're quantifying it, and the amount that we get reported is the area under the curve.
Okay.
And it doesn't always add up to 100%. So people get quite confused and go, it's not adding up to 100, it's only like 97%. And that's because each of the hemoglobins can have like glycated and denatured and these kind of like little changes.
Yeah.
And they make tiny little bumps along the way.
Okay.
And those are not always quantified.
Yeah.
Okay?
Yeah. That makes sense.
The other thing that is important is we calibrate the machine to something specific. So we will use the same machine to do hemoglobinopathy screening where we're trying to pick up the high A2s for potential beta thalassemia traits as we do for HbA1c for measuring response to, measuring diabetic control.
Yeah.
It's the same machine. It's calibrated differently.
Okay.
Okay.
Yeah.
And that's really important. So for the HbA2, we're calibrating it so that the sort of, 2.5 to 3.5% is super exact.
Yeah.
And then the rest might be off a bit, but it doesn't matter.
Yeah.
For the HbA1c, we're calibrating it specifically so that tiny little HbA1c peak is very accurate.
Yeah.
And then the rest doesn't matter.
Yeah. And HbA1c is the glycated HbA.
Yeah.
Yeah. Okay. Yeah. Cool. And just as a general concept then, with all of these, including HPLC, to look for a variant hemoglobin, like a hemoglobinopathy, like sickle cell disease, you're just looking to see the presence of the HBS in the HBS window. But for your thalassemias, for your beta thalassemia, the main clue you're looking for on HPLC is a raise in your HbA2 to about above 4%, so like 4 to 6% usually.
Yeah, sort of. It depends how you calibrate it, but sometimes it's above 3.5, 3.6%, but you have to look at what you're using locally, what your rates are using locally.
Okay.
But first of all, we forgot to talk about what hemoglobin A2 is.
Okay, yes.
Hemoglobin A2 is 2 alpha chains and 2 delta chains.
Yeah.
Okay.
Yeah.
And one of the concepts that's really important to interpret all of these results is to think about the beta. So along the beta globin gene, so the chromosome that has beta globin also has gamma globin. 2 alphas, 2 gammas, that's fetal hemoglobin, hemoglobin F. And it's got the delta. So 2 alphas, 2 deltas is A2, and then it's got the beta. So the reason why when you have a beta thalassemia trait, you don't have that beta globin gene working. So the enhancers that come and turn on the genes, they're used to, after you've done your hemoglobin switching after birth, they're used to just skipping the gamma and going straight to beta and a bit of delta. Yeah. But if there's no beta there because of the beta thalassemia trait, it's got to go somewhere.
Yeah.
And so it goes a bit more on the delta.
Yeah.
And that's why you get the raised A2.
Yeah. Okay? And so that's
also get a raised F because it can also go on to the gamma.
Yeah. Okay. And so that's the clue you're looking for to diagnose or to look for the first step in diagnosing a beta thalassemia on HPLC. But for alpha thalassemia, am I right in saying that the HPLC will be completely normal, but with thalassemic indices on the full blood count?
So yes and no. So alpha thalassemia is due to deletions in the alpha globin genes. We've got 4 alpha globin genes, 2 on each chromosome. And the more alpha globin genes are deleted, the lower the indices. So the lower the MCV, the lower the MCH. However, having lost some alpha globin genes, you can also reduce your A2 because we've said A2, hemoglobin A2 is alpha 2, delta 2, right? So if you've removed some of your alphas, then your A2 will be lower as well.
Yeah, yeah. And you're going to skew to normal. You'll use the rate limiting number of alpha genes to make more HbA rather than A2.
Exactly.
Yeah.
But it's not a reliable way of picking up alpha thalassemia.
Yeah.
However, if you're interpreting it and you go, oh my gosh, the A2 is only 1.6%, what could be happening? You could have some alpha deletions. Okay.
Yeah. Yeah, that makes sense. So thalassemic indices, look at HPLC. If the A2 looks raised, it's probably a beta thalassemia or something to do with that.
Yeah.
If the A2 is low or normal, then it could be an alpha thalassemia.
Yeah.
Just as a very, very basic overview.
Yeah, it's a basic. And also we would think, okay, hang on, let me check. I've got the iron because it could be because iron deficiency
could just be that. Yeah. Okay, brilliant. Okay, so that's HPLC. That's how it works. What are the major kind of pros to HPLC? You said you use it in Oxford as your first test.
We do use it as our first test, so it's quite high throughput. So we can do quite a few cases, all like hands off. I mean, partly it will depend on historically what your lab's been used to and your technicians and whether you've got enough money to buy a new machine or whatever. So in Oxford, we would use that as our first method. And our second method is isoelectric focusing.
Okay.
But a lot of places, I know in Derriford, you said you use capillary electrophoresis and then
a gel.
acid or alkali gel electrophoresis.
Yeah.
So talk about those.
Yeah, so let's talk about capillary electrophoresis next then. So that's Derriford's first test. And you said it was different to that of HPLC in that...
So it's very similar, but so you've got a capillary, so you can imagine this long thin tube, and you've got a buffer in it. And this time we're using an electric current to sort of drive through that buffer. Whereas with HPLC, we were only doing different salt buffers.
Okay, and then competing them off the column, the charged column.
Exactly.
Okay.
So now we've got electricity, we've got a voltage, and so the hemoglobins are moving along based on their charge and their mass as well.
Okay.
But the sort of tracing looks quite similar to HPLC.
Yeah.
And yet you also have peaks, you also do area under the curve, so it looks very similar to HPLC.
Yeah.
The advantage of that is it actually is faster than HPLC, so you can do more, I don't know, something like 2 or 3 times more samples in an hour.
Okay.
But also that whole thing about the A2 window, the hemoglobin E runs separately from the A2.
Yeah, which doesn't happen in HPLC, right?
Yeah, exactly.
Yeah.
So from that point of view, it's better.
And the traces are just neater. They're like nicer to look at, right? Because the HPLC ones have got much more bumps in them.
Yes. So if you're going for aesthetics, you could pick one.
I like the capillary electrophoresis better. Okay, cool. And I've got in my notes also that it's very sensitive. It can detect down to 1% and it can detect hemoglobin Barts. Is that all the same with the HPLC as well?
So HPLC, I don't know whether 1%, it's essentially like sometimes fetal hemoglobin is 1%. I would be happy with that. I would trust that. So we can talk about Barts and hemoglobin H. So hemoglobin H is 4 beta chains, so it's a beta chain tetramer. So hemoglobin H disease is when you've got 3 deletions of alpha, so you've got only one gene giving off alpha globin and normal amount of beta, but there's going to be an excess of beta compared to alpha because you've got fewer alphas. So all these betas floating around, what are they going to do? They can make a tetramer called hemoglobin H.
Yeah,
it's not
which is beta 4, right?
Beta 4,
which is a non-functional hemoglobin.
Yeah, it doesn't really carry oxygen around, and it precipitates. So it gives you, so when we do a blood film and we do brilliant crescent blue with the blood film, we can see these golf ball cells. That's the hallmark of hemoglobin H disease. And the hemoglobin H actually comes off on the HPLC very, very early. It's kind of got this saddle shape, kind of a bit like an H.
Yeah.
And then hemoglobin
right on the left, isn't it?
Yeah, right on the left, because it's so unstable, it comes off really quickly.
Yeah.
Bart's is even more unstable. Bart's hemoglobin is gamma, 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 gamma. So gamma.
4 gammas.
Yeah. So if you think about what is Bart's, the issue is that you've got no alpha globin genes at all.
Yeah.
You're trying to make fetal hemoglobin, so you're still making your gammas, but there's nothing to bind them. So they form an even more unstable hemoglobin called hemoglobin Barts, and that elutes even earlier than hemoglobin H.
Okay.
Yeah.
And is capillary electrophoresis better at picking that up?
I think it's supposed to be better at picking.
Yeah.
Is that survivable? Surely if
Absolutely not.
Okay.
Unless I guess uterine transfusions.
Yeah, so it's a really good question, David. And essentially it's called Bart's hydrops, right? Because and hydrops just means that the fetus has got lots of fluid accumulating around the heart, around the brain, around like ascites, pulmonary effusions, and it's basically severe heart failure because of such a severe anemia. Now we can actually pick them up because we know who's at risk. So if you've got two individuals that you've identified have alpha 0 and have a risk of a baby with BARTs, but for religious or other reasons they don't want to terminate, you can basically make your diagnosis very early, and you can do intrauterine transfusions, and then that baby will be like a thal major transfusion-dependent thalassemia. There are very occasional reports of babies who've survived naturally, and there's a really interesting research project looking at other alpha light chains like zeta globin and whether it's enough to sort of, overcome the defect of not having any alphas.
That research is happening in Oxford, isn't it?
Yeah.
That's very interesting. Okay, cool. And then just to finish on HPLC and capillary electrophoresis, when we have our patient that comes in with sickle cell disease and is having a chest crisis, for example, and we request from the lab the percentage HBS, we are effectively requesting either HPLC or capillary electrophoresis, whatever our first line test is. Is that right?
Yeah. And that's going to be because to work out, if we wanted to do a red cell exchange transfusion, we need to work out what's the current S percentage and what am I trying to get it down to.
Yeah.
And based on, I don't even know how to do it myself, but based on those and the body, the patient's height and weight and the hematocrit of the blood units, you can work out how many units to give them.
Yeah, exactly.
Sometimes people get quite hung up because nowhere can you get 24/7 HPLC or capillary electrophoresis results, right? Nobody pays a technician to come in the middle of the night to run this.
Oh, right. So you can't get it overnight.
No, you can't get it overnight. Most places you can't even get it at the weekend. And if it's somebody that's not been transfused, you don't need it because it's going to be 100% S or 50 S50C, right?
Yeah.
It's just if somebody's recently had a transfusion or they're on an exchange program, you don't know, have they got 60? Have they got 40? That's where it's going to be really important to know.
Yeah. And could you just take a sample and then crack on with a red cell exchange if you felt it was clinically needed and then test it when they're back in?
Yeah. Exactly.
Okay, that's cool. Okay, great. So then the next type of test is gel electrophoresis, which at Derriford is our second confirmed test. So once we think we found a variant hemoglobin on our capillary electrophoresis, we would then go on to do gel electrophoresis. Yeah. So do you mind telling us about the principles behind that as well, Noemi?
I'm going to describe both of these. There's acid and alkali, and then I'll describe isoelectric focusing, which is similar but has got some differences.
Yeah.
So most people know about what gel electrophoresis is in the sense that you make a gel with you've got these combs that have teeth to make little wells, and then again we're going to be lysing our red cells. We've got this kind of protein mix. We're going to put it in those little wells. The gel goes into this gel tank that has a buffer, and then we again apply electricity so that we've got a current, and then again these are going to move towards the hemoglobins are negatively charged. They move towards the positive end, and they will move based on their charge and their size. Now, the thing what I usually tell people about this is if you're going to go for a coffee while you put it on, you need to have a timer, because if you stay too long, you're having a fantastic conversation. By the time you come back, all your hemoglobins will have run into the buffer and you won't see anything. Okay?
I'm laughing because I've done this on one of my lab research blocks. I just ran it off the end. Yeah, exactly.
Whereas in isoelectric focusing, which I'll come on to later, that doesn't happen. So the gel electrophoresis is not very quantitative, okay? And you've got, again, you're gonna run a ladder next to it so that you know which hemoglobins are running where, but many things will run together at the same level. So once you've got your bands, you're sort of triangulating the information between what you got on your HPLC and what you got on your gel electrophoresis.
Yeah.
Most of the time you'll get an answer.
Yeah.
But then isoelectric focusing, the difference here is that the gel itself has got, and I have no idea how this is built or how they make it work, but the gel itself has got different pHs as it goes along.
Okay.
So as the hemoglobins migrate through this gel, they only migrate so far as their isoelectric point. So the bit of the gel that has the pH, that means there's no more positive or negative pull on them. Yeah. And they just stay. So you can't go for coffee and have a really interesting conversation because when you come back, everything's exactly where it should be.
Yeah, I see what you mean.
And it's much more, I mean, personally, I mean, I don't do the interpretation myself. If I had to do it for an exam or something, I'd much prefer to do acid or alkali electrophoresis because the bands are quite clearly separated. Whereas this is really to the untrained eye, it looks a lot more complex to interpret, but to the trained eye, it's got a lot better resolution.
Okay.
And you can see a lot more variance.
That's really helpful to kind of compare those two methods as well. So basically with both of them, though, they kind of create on the gel sort of band lines where different hemoglobins run. And then multiple different hemoglobins can land in the same band, particularly with the acid and alkali gel.
Yeah.
Okay.
Exactly.
And
you
we
can
basically
actually do one acid and one alkali. Like we tend to say most people do HPLC and a gel electrophoresis or capillary electrophoresis and a gel electrophoresis or isoelectric focusing, but you can do most of what you need with alkali and acid.
Okay.
So it's all with your resources in your lab, your expertise, how much time you have, how many samples you get that you need to do high throughut or not. Those kinds of things. Yeah.
And from having done gel electrophoresis in the lab myself, I know it is time consuming and really fiddly and requires loads of expertise. So not great for scaling up.
Yeah.
So I guess that's the major con of it.
I remember doing Western blots.
Yeah, exactly.
Part of my biomed, and my goodness, disasters.
Exactly. I think Western blots is even harder, but basically it's that kind of.
Yeah. And so the alkaline one is a cellulose acetate gel, or an agarose gel, and the acid one is a citrate agar gel.
Yeah.
Okay, and apparently, if you had to choose between an acid or an alkali gel, if you could only pick one, you would pick the acid one because it separates S and D, which the alkali gel can't do. Is that a fair comment?
Well, I think it depends on what two techniques you're using. So you want to make sure that you're using two different techniques where the bands that run together in one technique are not the bands that run together in the other technique.
Right. Yeah, got you. Yeah, that makes sense.
And actually, you've just made me think of something else, which is we're talking about variants, right? Hemoglobin variants, but we have to think about what about variants that are clinically significant versus variants that are not clinically significant. Because sometimes we see peaks and they might look quite exciting, but actually it's just a variant that from the clinical point of view, it makes absolutely no difference. It doesn't have a clinical consequence. So yeah, we've got to be careful that we're not sort of selecting for the variants that are not important.
Yeah, definitely. Okay. So that's gel electrophoresis, and then isoelectric focusing, you said was like a higher resolution version, essentially, because it's using the isoelectric point. And that's the method that's used for, it's your second test in Oxford.
It's our second method, yeah.
But also it's used for all the newborn screening from the blood spot test, or at least locally it is here. I think it's processed in Filton and Bristol. And so the benefit of it is that it can be used on very small amounts of blood and is very sensitive with high resolution, which is good. Okay, great. And then what about if you had somebody that had been transfused in the last 3 months? Where would you go with that one?
So essentially, it depends what you're trying to find out. And when we do the interpretation one, that's one of the things that we always have to be thinking about when we're looking at peaks. If we've got more peaks than we expect, we've got to think, has this patient been transfused? And sometimes people get themselves into quite a pickle going, well, if they happen to have been transfused with one unit that had this, we've got to be sensible and think about what are the
It's like quite a rabbit hole you can go down there.
You can. It can be quite fun, right? Also keep it clinically relevant. But if somebody's been transfused, obviously we can't interpret a lot of these tests because there'll be more bands than we expect. So for example, imagine somebody with SC, so you'd see those two bands, but if they'd been transfused, there would be some A as well. You've got to think about if somebody's so we don't give, for example, sickle trait blood to people with sickle cell disease.
Yeah.
But somebody who's just having a transfusion because
like for an RTA or something.
Yeah, exactly. They might happen to have somebody with sickle trait, be transfused with blood from someone with sickle trait, in which case suddenly an S would appear. And if you, like all of these tests, to be really sure, if you have any doubt, you send it off for DNA.
Yeah.
Okay.
Okay.
That's the main
So
thing.
gene sequencing, like genetic test, is what you need to do basically if they've been transfused in the last 3 months.
Yeah. Yeah.
Okay, fine. And I guess that's also useful antenatally if the fetus is not making enough of the beta chain, if you're looking for like...
So if we are doing screening and we've got we know that mum is a beta thal carrier and dad is a beta thal carrier, then we think, okay, we need to test the baby. This is assuming that the couple would want to have a termination if the baby was affected. But we don't get like blood from the baby and then run an HPLC. That's not how we do it. And also they would be making fetal hemoglobin anyways at that age.
Right.
So what we do is we do DNA analysis, and we're working with we're not taking blood from the baby, we're taking chorionic villus sampling or amniocentesis.
I see. Okay. Yeah, that makes sense. Brilliant. Okay, so then I guess the only other thing that I wanted to ask about was the sickle solubility test. So my understanding about this test is that for any abnormal or variant hemoglobin, a bit like what you were saying earlier about whether a variant is clinically relevant or not, obviously that can be completely dependent on what the variant hemoglobin impact is. So if it's like hemoglobin E, was a thalassemia variant, so that might have a different impact to that of HBS, which can sickle, and then other variant hemoglobins, which by themselves might not be a problem, but if co-inherited with HBS can sickle. So the sickle solubility test is a bit of a crude kind of quick and dirty, cheap test, but to kind of see whether the variant hemoglobin that we've identified has the ability to sickle.
Yeah.
Is that fair?
Yeah. That's fair. And I mean, I don't personally think it's that important. I don't know if anybody's going to write in. Do you have a complaints department?
Yeah, we do.
Write in, and
we'll ask Ada to filter it for us.
All right.
I like the sickle solubility test. Why don't you like it?
I don't see the point, because I think, like, when people say, well, you use it in an emergency.
Yeah. What if you're someone who has an operation, like needs an operation, and you've had a full blood count and a blood film that suggests they've got sickle cell disease, they're from out of area or whatever, and you want to know if they are... I guess it isn't going to distinguish between... So sorry, we should talk about the test first before we talk about this. So basically you take your red cells, you lyse them again, is that right? And then add sodium hydrosulfate, which then causes the precipitation of HBS. And so the solution is like clear initially, a clear lysate, and you can see like a ruler behind it. And then if you have more than 15% HBS in that solution, then it turns turbid on addition of the sodium hydrosulfate, because the HBS sickles and makes it turbid. So it's like a quick screen to see whether there's HBS. But I guess one of the issues, which is probably why you're going to say that you don't like it, is that it can't distinguish between a carrier or a trait versus someone who's infected.
Yeah. And also, I mean, a carrier, you wouldn't see sickle cells on the blood film anyways. So
that's true. Oh, yeah. Yeah.
But what the reason it annoys me that people bring it up, although, you know, it is done in a lot of places. But what I think is, like, when people say, oh, well, if it's an operation, then even if it's a sickle trait, you'd want to keep the patient warm and well hydrated, oxygenated. Do we not try and keep all our patients warm and hydrated and well oxygenated? You know, I don't really think that we're doing anything different for the sickle trait.
What about cell salvage, though? You wouldn't do like red cell salvage?
Yeah, you might not do cell salvage, but in a way, if somebody, you'd be able to tell. Cell salvage doesn't tend to work very well in people with sickle cell disease, SS.
Okay. Yeah.
And again, actually, if you're trying to distinguish SS from SS from trait, you could look at a blood film.
Yeah.
Anyways, we must learn about it, and we do. A lot of places do it, and essentially, it's a quick and easy test. It tells you whether the hemoglobin that's in there can sickle or not.
Yes. And
moving swiftly on.
That's it. That's all you want to talk about with that.
That's all I want to say.
Fair enough. I guess the other caveats for exam purposes are if you've been transfused a lot, then you could have a negative test and still have HBSS. And if you're really anemic, you might not get a positive result either. It doesn't mean you don't have HBSS. And infancy as well, it would be potentially negative. So don't do it in somebody under the age of 6 months. And then I'll stop talking about sickle cell solubility in the interest of not annoying Dr. Roy any further. Okay, cool. That's helpful. Great. That's all I had to say about this topic. So
I think we should do a sense check with David.
Okay, good idea.
I guess yes, thank you
whatsoever.
bring the layperson in.
You're not a layperson.
So I guess the thing that I worry about, not worry, doesn't keep me up at night, but I don't want to embarrass myself making referral to a haematologist when it isn't warranted. Mm-hmm. So I guess
I wish you could speak to a lot of GPs.
I'm always very kind. I'm like, oh, would you mind giving me a job in the future? So I want to get this right.
Excellent.
What just in a nutshell, what do I need to have done before I should even consider getting in contact about maybe a thalassemia or a hemoglobin variant? What things would you expect from me?
So I guess the first thing to say is it's very different whether you're talking about contacting the lab or contacting a clinical hematologist. So I would say the lab would always be happy if there's anything you don't understand in a blood result, and that could include the indices, that could include, something on the HPLC. The lab will always be absolutely delighted to be contacted and to advise about whether or not you need to do additional tests. I think what confuses a lot of, let's just say GPs, because that's mostly people who can't get in touch with us, is on an HPLC where we would report and say, we would suggest checking there's no variance, but we would suggest checking iron studies. If iron replete, then it could be a thalassemia, alpha thalassemia trait. And that tends to freak people out. Sometimes we get immediate referral, urgent referral to red cell clinic, which is not appropriate because alpha trait is not going to have any impact at all. The only times we're going to need to know about it is alpha 0 in the context of babies, basically, and the risk of passing on a serious hemoglobinopathy.
And the concern for alpha 0 comes from certain ethnicities.
Yeah.
And also the MCH being below a certain level, right?
Yeah. Yeah. So it's the indices and we call it family of origin questionnaire. So it's where people's family is from. But essentially, if you're the hematologist, even clinical hematologists, will always be happy to be contacted for advice. And even if that advice is just, do I need to do anything else? I think what would annoy people is if, for example, the hematinics haven't been done. Okay, so that would be quite annoying. But and then I've said this earlier as well about we can't really be running HPLCs just for fun, just because there's something potentially quite interesting here. We have to check that the patient has given consent. My personal feeling is that we should probably be testing more people. So at the moment, we'll cover this in more detail when we do the screening session. But at the moment, the whole screening session is set up in such a way that we wait for people to be pregnant. And then we think, okay, are you going to want a termination, which is not brilliant. So I think if you're, in a general medical job and you see someone who's got really thalassemic indices and you've thought, I wonder if it's iron deficiency and the iron is completely normal, and you think, and this is somebody of childbearing age, I think it's not inappropriate to say, well, we should test. And if you're beta thalassemia trait, then maybe this will impact who you decide to want to have babies with, or that you might want to get your partner tested so that you can have pre-implantation genetic diagnosis. So I'm all in favor of people being tested if there's a good reason for it.
That makes sense.
Even in just an unexplained anemia, so not hemolysis, hematinics fine, but not thalassemic indices.
Then we're sort of onto the R92 panel, which we again can cover another day. But all the sort of genetic anemias, we've got the whole iron. But
you do HPLC and the stuff that we've talked about today first.
If if the indices are completely normal, no, I wouldn't do HPLC.
Okay.
Yeah.
So even if it might be a person with a carriage of sickle cell, that would be because their indices might be quite normal, right?
Somebody who's a sickle carrier should not be anemic.
Oh, okay. Yeah. I see. Yeah. Okay. That's great. Brilliant. Thank you so much. That's really enlightened me. And I don't know if we should wrap up with like the 3 golden nuggets, which is kind of what.
Yeah, I think that's always a helpful takeaway.
Yeah.
All right. Okay. Let's
would
go
you
for
like
it.
to suggest them, Dr.
I would love to suggest the 3 golden nuggets. Golden nugget number 1, you're not going to do any hemoglobinopathy interpretation without looking carefully at the full blood count, the indices, and the iron studies. Number 1.
Yeah.
Number 2, you're pretty much always going to need 2 methods. One screening-ish method and then one confirmatory method. Okay.
Yeah.
And number 3, practice. Honestly, most hematology trainees are not interested in practicing this until it's like coming up
Just
to their
before the exam.
Yes, and then suddenly I'm very popular. But really, I would say if somebody's doing their 5-year training in hematology, a lot of the labs are running these, and there'll be tons and tons to practice on. And I'm not saying get stuck in with hemoglobin lipours and constant spring and all these weird and wonderful things. No, I'm talking about, can you pick up an S trait? Can you pick up SC? Can you? And that is just practice. And I think there's a lot of fear around these cases, and I think just having a look at one once a month probably will take that fear away.
Yeah, definitely. I don't know in other places, but in Derriford we're really lucky because we have a red cell queue that comes through every few weeks, and you can just grab that and get printed off, and you can just look through them and make sure that you know how to interpret them. There are some other good resources just for people listening who are wanting to do more practice. So Learn Heme is a good website. They're not all completely accurate, as we did discover, Dr. Roy, when we went through some of them. But it's a good place to start, and there's good questions there. Obviously, question banks as well. And there's loads on the Path portal, which is really helpful, the NHS Path portal. So yeah, there's loads of HPLC to find and do for practice. Great. Thank you so much for your time. This has been so enjoyable. I can't tell you how much I've enjoyed it. So thank you.
I'm sure the listeners at home have enjoyed a different voice as well.
Exactly.
Just us droning on.
Yeah.
But yeah, it's been really enlightening. Thank you very much.
Thank you. All right.
Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time!